Okay, welcome everyone to our third LGBTQ plus health grand rounds. These are very new, but I gotta say, Peyton and I can't keep up with the number of exciting speakers that we can feature. And so we are booked out for months now. But we are so excited to bring Brian Nuyen to the stage today. Brian just started recently, I think it was early April, whenever you joined the team, has joined us as an otolaryngologist focusing on gender-affirming voice work. And I just am so glad we got you right whenever you're starting because I learned so much from speaking with you. I know that our community is going to love to speak with you and learn from you. I also know that you're one of a kind in your training and specialty. So we're honored and lucky to have you here. To go ahead and kick us off, I'm going to do a brief bio for you. But I do want to go ahead and say to everyone, thank you so much for being here. Welcome. We're like a little over a month away from Pride. And so I know there's a lot of exciting things happening to gear us up for this. And actually, before we get done, Anne-Marie, I hope you'll share any information we can about the all hands, because I know that that's coming up as well. So feel free at the end, we'll give you a little time if you want to say anything about that. But to get us started on our talk today, so Brian Nguyen completed his otolaryngology head and neck surgery residency at Stanford Medicine here at Palo Alto, where she developed a keen interest and passion for head and neck affirmation for transgender and gender non-binary communities. He completed his James Thomas, MD Voice Surgery Fellow from 2021 to 2022 in Portland, Oregon, subspecializing in gender-affirming voice medicine and surgery, and was a visiting fellow in summer 2022 with Dr. I hope I don't pronounce this incorrectly, but please feel free to correct me, Dr. Hyung-Tae Kim at the Yeson Voice Center in Seoul, South Korea, with a focus on international perspectives on gender-affirming and endoscopy. This is where I struggle with the medical language, and vocal surgical innovation. So I will hand it over to you, Dr. Wed, who could probably introduce a lot of that better than I could pronounce it.
No problem. Thank you so much for having me. I'm just going to go ahead and share my screen here. Thank you so much for that kind introduction. Let me just go ahead and get started with our presentation here. It's a huge honor. I'm so grateful to be sharing my thoughts and particular historical and research and future perspectives on vocal gender affirmation, which is a topic that I care so deeply about. I'm very grateful to be sharing with you all as part of our Stanford community here at the LGBTQ plus Health Grand Rounds. Like Blaise mentioned, my name is Brian Nuyen. I use any pronouns. I'm one of the new clinical assistant professors here in the Division of Laryngology at Stanford's Voice and Swallowing Center within the Department of Otolaryngology-Head and Neck Surgery here at Stanford. So thank you. I have no particular disclaimers. One of our primary objectives today is to understand how vocal structure and function can communicate perceived gender, and how we can leverage that anatomic and physiologic understanding to explore treatments and the frontiers of such treatments in terms of vocal and gender affirmation for our transgender, gender nonconforming patient communities. But first, let's talk about the invisible force that rules us all, particularly gender and the gender binary. What is the gender binary? This may be something that you all study academically or see specifically clinically as well within your practice, but just to make sure we're all on the same page, gender binary is a very powerful social force that is based on the belief that sex is binary and that this binary nature of sex directly determines gender. Sex is a particular understanding that it is the biological makeup of an individual, including the chromosomes, the anatomy, the hormones, the transcription factors, and unto itself is non-binary. Gender is a particularly very distinct phenomenon, and it is a social construct or social understanding of what it means to be a man and or a woman in a specific culture based on time and geography, and is entirely fluid and also based on self-identity as well. What does it mean to be transgender? Transgender people have gender identities different from the gender they were thought to be at birth. For example, trans feminine folks or trans feminine women consider themselves or know themselves deeply to be women or feminine. despite being assigned male at birth. And conversely, transmasculine men or transmasculine folks consider themselves to be male or masculine despite being assigned female at birth. These our transgender patient communities and transgender folks in our society often bear the brunt of the social stigma of the gender binary, and there can be very severe, even violent consequences from folks within our society and within the social, societal, political forces that enforce the gender binary. Per the National Center of Transgender Equality, I use male, female, man, and woman per their gender identity and not their sex. Importantly, everyone has a gender identity, including me, including all the folks here on the Zoom, whether or not they are transgender or not. And a lot of folks have the privilege of not necessarily having to think about their gender identity constantly on a daily basis because their internal sense of their gender is aligned with how folks see them. And so that particular privilege can lead to a lot of particular fluidity in their social interactions and also have a lot of benefits for their physical and mental health as well, whereas other folks really fight against this particular barrier where their internal sense is not matched by those who perceive and validate that from an external perspective. Again, aligned to and resulting from the powerful stigma associated with the proscriptive gender binary. Gender dysphoria is an ICD code, literally a medical diagnosis that's based on the distress from the contrast between the gender folks are thought to be at birth and the gender they know themselves to be. It's really critical to understand that transgender folks are not necessarily, being transgender itself is not a particular medical diagnosis unto itself. But in fact, the gender dysphoria, which is often a result of the social stigma from being transgender in a society that enforces the gender binary, that leads to the psychological distress and the whole host of adverse health outcomes that can arise from that discrepancy. Gender dysphoria can be relieved by expressing one's gender in a way that a person is comfortable with. And like I said before, being transgender is not itself considered a medical condition. Even nowadays with folks with gender nonconformity being more accepted, especially when our younger generations, a lot of folks are experiencing their gender in nonconforming ways in really healthy, happy means, which is really exciting to see, especially for our younger generations. The alternative to gender dysphoria, the converse aspect of that, is gender euphoria, in which there can be multiple dimensions, including cognitive euphoria, this idea that I love myself, that I'm lovable as my authentic self, social euphoria, being recognized by the correct pronouns in their name, and body euphoria, the idea that our bodies feel like our own, something that we wish for ourselves, for our loved ones, for our patients, which is a really particularly powerful mean of self-expression and self-recognition. Gender transition is a time period in one person's life where they begin to live their life in a way that is aligned to the gender they internally identify with. And the key thing is that this particular transition looks very different from person to person. There's no prescribed algorithmic way that a gender transition can occur. And there are other dimensions that gender transition can occur including medical, legal, social, personal, psychological, surgical, a lot of different ways that gender transition can manifest itself, and it's very personal and intrinsic and oftentimes very custom. Based on all of these understandings of how gender binary can enforce the ways that we express ourselves and ways that we as individuals can seek our own and harness the own power of our own authenticity to express ourselves, understand who we are with the outside world, particularly in the dimension of gender. Using that information, we can also use what we know from a head, neck, anatomic, and physiologic standpoint to better align our gender identity and the way that we consider, particularly our voices, to be with the outside world. Fundamentally, our voices are who we are. A lot of research studies have shown that our voice within milliseconds can communicate not only gender, but such social attributes including age, health, wealth, intelligence, sociability, trustworthiness, and all those particular social characteristics are deeply embedded and manifested as data within our voice. Zooming out a little bit about how our voice is produced, I'd like to focus on this kind of cross-sectional anatomy here, where at the very center of the screen, you see the word glottis, which is a description of the vocal cords or vocal folds themselves, which are basically two folds, which we can kind of theorize physically as strings, with a core of muscle wrapped in an envelope of mucosa that come together for speaking and swallowing and vibrate together to produce sound and come apart to breathe and let air exchange with the lungs below. And just wanted to let you all know I'll have some content warnings throughout the presentation showing endoscopy videos and intraoperative photos for you all to understand. So here is a YouTube video from the National Association of Teachers of Singing demonstrating normal stroboscopy, which is using a light in rapid frequency to catch in slow motion what vocal fold vibrations look like.
No vibrato.
You can see here in this video that the vocal folds look pearly white. They are very symmetric in how they appear and how they move apart and come together, and that the vibrations are, and the mucosal wave is quite symmetric. And that's considered normal for this normal exam. And stroboscopy is a powerful tool that we as laryngologists use to evaluate and diagnose vocal conditions. So now that we kind of understand what vocal anatomy looks like on a physiological normal basis, let's understand how exogenous and endogenous hormones, particularly testosterone bioactives, can help transform the larynx. So in these diagrams here, we can see how exposure to testosterone can increase the size, the diameter, and the anterior projection or the forward projection of the thyroid cartilage or the larynx. And testosterone, like other testosterone bioactives, have a lot of particular effects on human muscle. Particularly muscles expand, become bigger, larger, bulkier, heavier, thicker. And that's also true for muscles within the vocal fold. Vocal folds, like I mentioned earlier, have a core of muscle within them, and that core of muscle is called the thyroarytenoid muscle. And exposure to testosterone bulkens that particular muscle, increases its length, mass, diameter, and makes it heavier as well. And that decreases the pitch by decreasing the oscillations of that particular string, leading to a deeper voice. We can see here also that there are changes to the cartilage of the thyroid cartilage and laryngeal framework, as evidenced by these CT scan cross sections, making the in panel D, for example, compared to panel B, the increased angularity, the acute angularity of that thyroid cartilage that is also apparent in the sagittal cuts below. This interesting study from a colleague of mine in Sweden looked at women with congenital adrenal hyperplasia and virilized voices, and kind of helps demonstrate the dose-dependent quality to testosterone and testosterone bioactives. Here in this diagram here, we can see that the mean fundamental frequency decreases with increasing exposure to testosterone with folks who are assigned female at birth controls versus folks who are assigned male at birth controls, and women who have congenital adrenal hyperplasia with greater testosterone bioactives in their system, leading to that dose-dependent manner of their fundamental frequency, decreasing the quality of their voice and the pitch of their voice. The thyroarytenoid cross-sectional area, the thickness of that muscle cord in the middle of the vocal cord, also increases in diameter as well as the length as well, which kind of goes back to this physics-based understanding of the vocal cord or the vocal fold as a string. That fundamental frequency is a function of tension, mass, and length. And then we can leverage these particular variables as surgeons to help influence fundamental frequency. By increasing tension, like tightening the guitar string, we can increase fundamental frequency. By increasing the length of the string, we can deepen fundamental frequency. And by increasing the mass of the string, that also decreases fundamental frequency as well. Here along the piano are kind of the epidemiologic or population-based studies of where the male and female, folks who are assigned male, folks who are assigned female at birth, fundamental frequency pitches lie. But we need to understand, and it's really important, all of us as a community of voice professionals and healthcare professionals and patients and folks in society, that gender perception in the voice is so much more than just the pure isolated pitch or the pure fundamental frequency. It includes things like resonance, intonation, the rate of speaking, the quality of the intonation, the ups and downs in the melody of our speech, the words that we choose, our nonverbal behaviors, the way that we articulate and enunciate. All of that is very gendered socially and internally, and is outside the beyond the control of the glottis and the control of what I can do as a laryngologist as well. Additionally, it's important to understand that another key factor in our vocal production is our brain, our central nervous system. I always tell all my patients that the voice and the larynx, or the voice box, is an incredibly emotional organ. We all know that our voice box is connected deeply to deeper structures of our brain, including our limbic system, as well as other emotional centers of our brain. And when we work with our transgender, gender-nonconforming patients, a lot of those patients, and a lot of us here in our, in this room too, have sometimes complex emotions and meta emotions about our voice, including excitement, shame, guilt, embarrassment, pride, love for our voice. And it's really important that we tease out all of those complex emotions that influence vocal production and perception of our voices as well. So it's all these factors: the central nervous system, our voluntary, involuntary emotional control from a brain perspective, the resonance chamber of the pharynx, the lips, gums, teeth, tongue, palate, pharynx, throat, that influence intonation, resonance, articulation, and the fundamental frequency, the string theory, the glottis unto itself. And it's all these complex factors that we think about in terms of vocal production. I wanted to show you all an endoscopy video. I was lucky to work with a vocal coach in Portland by the name of Anna. She herself is a trans feminine woman, and counsels a lot of patients in helping feminize and masculinize a lot of her gender nonconforming patients. And we were lucky to work together, where I was able to pass an endoscope through her nose and have her do a variety of vocal exercises for us to see what her voice looks like during these exercises here. So Anna, what were you doing there?
I'm breathing in a way that shifts the voice box to a higher position, and I'm narrowing the pharynx, the throat, to reduce the size and space of the resonant chamber, which is going to create a more feminine vocal tract.
And so we can really see in that particular diagram that she brings her arytenoids, which are cartilages that act as puppeteers to the vocal cords, really curled in, and the whole pharynx, or that resonance chamber, is turned from a flute into a piccolo, which makes the resonance a lot more feminine. This is in contrast to the masculinized exercises that she does and demonstrates here, and you can watch and see the difference. So it's really beautiful the way that you can see the way that Anna very skillfully arranged the resonance in her voice. You can see, compared to the feminizing resonant breathing techniques that she did, this way the pharynx is so much more open. She flipped her arytenoids outward, backwards. The back walls here and the side walls really opened to help create a really much more masculine resonance. Yeah. And you can kind of see in that endoscopy video that her pharynx, unlike a flute turned into a piccolo for the feminizing vocal exercises, the pharynx is expanded to kind of be almost like a cathedral in this huge vocal space, this pharyngeal space, where the overtones can echo around repeatedly and help darken the quality of the voice and make the perception from an auditory perspective a lot more masculine. So using what we know about the larynx now, we can start to learn how to achieve vocal authenticity for our patients. In our society, it was important for us as a research group here at Stanford to understand how important it is for our gender to be accurately represented in our voice. So what we did was a cross-sectional study of over 2,500 adult survey respondents across the United States, spanning all 50 states. And the vast majority of these survey respondents were cis, straight adults. And we've got some very interesting results for this study. Using health utility exercises, we found that our cohort accepted on average a 15 to 20% risk of death during a hypothetical vocal gender dysphoria treatment to cure their condition, highlighting the severity of what they thought was the disease burden associated with having a voice that did not match their own gender. Using another health utility exercise, we found that these folks who were, again, primarily cis straight folks, were willing to give up 10 years of their remaining life in order to get their vocal gender dysphoria treated to cure their condition. And in another exercise, using a monocular blindness control, we had them rate the health disease burden associated with having one eye blind. And we found no statistically significant difference between having the health burden of having one eye blind and having a voice that did not match one's gender. And fascinatingly, we had folks self-identify before they did the survey as liberal or conservative or Democrat and Republican, and there was no difference in the severity of their scores rated among those respondents who felt that they were more blue politically than red politically, highlighting that despite political affiliation, most folks saw that having vocal gender dysphoria was a severe health burden. Focusing now on our trans-masculine folks and what we can do for them. One of my mentors here, Dr. Damros, who is the chief of otolaryngology in my division, was one of the first to document in a case report longitudinally the effect of androgen therapy on a larynx of a person who was assigned female at birth. If we can see based on these studies here by Dr. Damros that the fundamental frequency dropped in hertz precipitously around 3 to 4 months on T and stabilized thereafter. And that was true also for vocal range as well. Again, my colleague from Sweden, Dr. Nygren, did a cohort study that was also a longitudinal study measuring the fundamental frequency and patient-reported outcome measures for trans men as well. And Dr. Nygren found that around the 6-month mark, there was a plateau that was stable for 12 to 24 months in terms of the fundamental frequency over time. Additionally, a lot of the patient-reported outcome measures indicating transmasculine vocal satisfaction or satisfaction with their voice use and identification kind of peaked around 12 months and stabilized thereafter. Aaron Ziegler was a colleague of mine when I was in Portland. He was faculty at OHSU and published this very interesting meta-analytic review showing that while the vast majority of transmasculine men taking testosterone were happy with their voice, 20% of them required additional adjuvant treatment, including surgery and voice therapy, to help stabilize their voice and achieve their vocal needs with or without systemic testosterone. And that's where really our speech-language pathology colleagues really are powerfully needed for this community. In fact, the 8th edition of the WPATH Standards of Care for Voice, WPATH being the World Professional Association for Transgender Health, really helped dictate and guide a lot of folks in understanding the power and the importance of first-line speech therapy in accomplishing a lot of the health goals for the vocal needs for our transgender patients. Additionally, we also have surgery that we can offer here at Stanford, particularly type 3 thyroplasty, which was kind of documented in this study by a Dutch group, where parasagittal cuts along the thyroid cartilage are made, which then depress the anterior commissure of the focal point of the vocal folds, relaxing the vocal folds, basically slacking the guitar strings, which then decreases the fundamental frequency for these patients. And here are the perioperative outcomes here. What about our trans feminine patients? What can we do for our trans feminine colleagues and patients for their vocal needs and their ways that they understand and have expressed their needs for treatments for their vocal gender dysphoria? Again, it goes back to this understanding of how CNS control, pharyngeal control, and glottic string theory all come together to accomplish these goals for our trans feminine patients. Again, with the 8th edition standards of care, first-line therapy is speech therapy because it's a very low risk and high yield method to accomplish a lot of the goals for these patients. However, surgery can sometimes play a role, and historically, one of the first surgeries invented for this procedure for feminizing vocal pitch was the cricothyroid approximation, where stitches along the thyroid cartilage here, where the 1, 2, 3 are marked, to the cricoid, which is the cartilage below, are sutured, rocking the whole thyroid cartilage forward compared to the cricoid cartilage, tensing the string and thus increasing the fundamental frequency. There's an important study by Dr. Chitsi in silico that looked at how we can accomplish glottoplasty for these patients and how we can increase fundamental frequency while not exposing the patients to unnecessary risk to other factors of their voice. And so they used computer modeling to show that placement of a stitch to web the vocal folds is best at the 50% mark. And this web, which I'll demonstrate shortly, is a really key and exciting and common way to feminize the voice endoscopically without any scars along the neck. In terms of comparing the web technique with the cricothyroid approximation, it was really shown in this particular study that cricothyroid approximation, while increasing the baseline fundamental frequency, had pretty dramatic pitch reduction consequences. And so nowadays, cricothyroid approximation is done a lot less frequently in the United States and across the world in favor for when there's glottoplasty or other endoscopic webbing techniques. Here's some intraoperative photos in this next slide that I wanted to warn you about. One of my mentors, Dr. Orloff, here at Stanford, was also one of the first to publish use of laser technique, and I apologize for the outdated terminology here in this paper in 2006. But Dr. Orloff here was one of the first to show that by decreasing the mass of the vocal fold by using carbon dioxide laser intraoperatively to decrease the mass, again, going back to that physics equation where we understand fundamental frequency as a function of mass, tension, and length. By decreasing mass, we're able to increase fundamental frequency. And we use this as a perioperative adjunctive tool for our transfeminine patients. And here are the perioperative outcomes here. Excitingly, I'm really happy to offer here at Stanford a technique that Dr. Kim has famously published back in 2016, the vocal fold shortening retrodisplacement of the anterior commissure, or VFSRAC for short. Where a stitch is placed along the 50 to 40% mark along the vocal folds, that then acts as like as a finger or a capo along the frets of a guitar, increasing and modulating the pitch of the voice higher and decreasing the vibratory length of the functional vocal folds, which accomplishes a lot of the goals for the patients in feminizing pitch. Additionally, by de-epithelializing the anterior subglottis, or in the red triangle in the diagram below, by attaching the stitches to the front part of the vocal folds below the vocal folds, there's an increasing tensing effect and a funneled effect that Dr. Kim has theorized that also feminizes the resonance of the voice as well. I was lucky this past summer after my official fellowship to spend a good chunk of my summer with Dr. Kim and his colleagues in Seoul, South Korea, learning from him. I was fortunate to see that he does this, this surgery 5 times a week for patients both in Korea, and while the vast majority of his patients were outside of Korea, including China, Russia, Kazakhstan, Brazil, Mexico, Germany, France, and many patients in the United States would fly to come seek his expertise, as Dr. Kim is one of the only few places where VFS-RAC is offered in the world, soon to be offered here at Stanford as well. Here's some photos from my trip. I got really close to Dr. Kim and his colleagues. In the far left are his speech language pathologists I worked with on a daily basis. In the upper right corner, patient care coordinators and the speech language pathologists that I got really close to. They offered a lot of food recommendations in the area, and we bonded over a lot of K-pop that they helped introduce to me. And so very grateful to bring the Korean technique, which is one of the most sought after techniques in the world, and have it available here at Stanford in the United States. I also was very lucky to learn from my fellowship mentor, Dr. James Thomas in Portland, Oregon. About 20 years ago, he invented this procedure called feminization laryngoplasty with thyrohyoid elevation as a modification from a prior procedure, which I'll explain shortly here. Feminization laryngoplasty is an open surgical technique that aesthetically modifies the contour of the voice of the voice box to feminize the contour of the neck, as well as feminize the pitch and resonance of the neck as well. And the way we do that is by removing an anterior strut of the thyroid cartilage, which includes the Adam's apple. We resect 50% of the true and false vocal folds here. We suture them together and tie it forward. So then by resecting the vocal folds in this manner, decreasing the mass, by stretching out the vocal folds, increasing the tension, and attaching that particular new anterior commissure to a plate, closing the voice box anteriorly to secure that new fret for the guitar strings. We remove the top part of the thyroid cartilage and suture the whole construct up to the hyoid bone. So basically like a tuba, moving the larynx closer to the lips, decreasing the amount of space that the overtones that can resonate, then kind of turning that flute into a piccolo and moving that slider on the tuba upward so that the source of power for the voice is closer to the lips and the overtones don't echo as much, leading to much brighter sound and much more feminine sound as well. And so here's some intraoperative photos. This is a preoperative surgeon's view of what the neck looks like right before we make our incision. This is an exposure of the vocal folds here. Well, after we make our remove the anterior strut in the Adam's apple, we then put a marking stitch along the 50% mark of the vocal folds. And we then resect 50% of the vocal folds to decrease the mass and increase the tension by putting these horizontal mattress sutures that then tense again the vocal folds to retune the guitar strings, and then attach those new guitar strings to a new plate that closes the voice box here, which is kind of the final photo there. And this kind of demonstrates what we remove, which is the top part of the thyroid cartilage, the central strut of the thyroid cartilage, and the true and false vocal folds there. And that is an immediate postoperative view where we can see we really feminize the larynx in addition to feminizing the pitch and the resonance as well. We published a 17-year review of all of Dr. Thomas's patients as part of a retrospective case series. We found that a lot of our patients sought care elsewhere and had previous voice surgery. And also a lot of them had cosmetic chondrolaryngoplasty, which is colloquially known as the tracheal shave. And unfortunately, almost half of them had a voice complication before coming to see us as a result of this aesthetic surgery. In terms of our perioperative outcomes for feminization laryngoplasty, on average, there's a 50% hertz improvement and increase in their speaking pitch, and almost a 60 hertz improvement in their lowest speaking pitch, or along about 7 semitones or 7 half steps along the piano, resulting with no change in their highest pitch, resulting in a pitch range decrease. We had a single item third-party perception self-report measure of patient-reported outcome measure of how often they were perceived as female over the phone, and there was a 60% increase in that perception. There are complications and revisions associated with this surgery. The most common complication is infection. And within the 20-year history, there were 2 patients that had required a temporary tracheostomy as a result of this procedure. To analyze the durability of these outcomes, we bucketed the groups of patients in those who had less than 1 year follow-up and those who had greater than 5 year follow-up. And as you can tell with these patients, follow-up can be quite difficult because these patients often travel pretty far for their surgical and medical care. And so follow-up wasn't always documented for these patients. Nonetheless, we were able to show that folks who had less than 1 year follow-up and folks who had greater than 5 year follow-up had no statistically significant difference in their outcomes, kind of indicating as a surrogate measure the durability of this procedure's effects on the voice. One of the key things that we wanted to dig in deeper on this study was that that patients who had an Adam's apple removal prior to seeing us, almost half of them had a voice complication as a result of that procedure. So we wanted to learn more about that and do a deeper dive, because the way that our current field as otolaryngologists understand tracheal shave or chondrolaryngoplasty, or the removal of the Adam's apple, it's thought to be a relatively safe procedure for the voice. But it's important to know that the vocal cords attach pretty close by to where the surgeons work in removing the thyroid notch or removing the Adam's apple. And particularly aggressive surgeries or surgeons who are not particularly aware that the true vocal cords attach close by to where the Adam's apple is, when they remove the Adam's apple, they can also dislocate the attachment of the true vocal cord. Kind of in contouring the end of the guitar, they can actually hit where the knobs kind of help control the tension of the string, thus loosening the vocal cord, creating a deeper voice, which for a lot of our trans feminine patients is a particularly adverse outcome. So based on a technique that was pioneered by Dr. Spiegel, who is a very famous facial plastic surgeon who does facial feminization surgery for the transgender community, Dr. Spiegel, we adopted the same technique that he does in the operating room that we do at bedside, where we kind of basically feel where the resection of the tracheal shave or chondrolaryngoplasty has been done, and using a scope, help measure and diagnose whether or not the anterior commissure or the vocal cords are dislocated as a result of this procedure. And so we were able to show that this is actually quite common, unfortunately, among these patients, and that the safety concern is often misdiagnosed and understudied. for our trans feminine patients. The most important number I want to show on this slide here is that it took on average for our patients 5 years to present to a voice specialist after a chondrolaryngoplasty. I think that's a product of social stigma and barriers to care for the transgender and trans feminine patient community, that takes them often 5 years of experiencing a hoarse voice or a deeper voice in order to seek the particular subspecialty care. That's something that we hope to address here at Stanford. By using feminization and laryngoplasty to reconstruct and relocate the vocal cords after dislocation, we're able to accomplish improved feminized pitch in speaking, lowest and highest pitch for these patients as well. We all know in our society here today, these are really particularly fraught times for the LGBTQ plus community, and particularly for the gender nonconforming transgender communities here, with almost 400 to 500 pieces of legislation that are actively being discussed or currently active in these particular states. From this slide here from amfar.org really shows the extent of the wave of the tsunami of systematic political oppression that these patients experience. And so it's really important that we think of how we can address this rising tide and this true rising tsunami of systematic discrimination for these patients, and how we ensure equality for these patients. Really, fortunately, excitingly, as you all know here with our LGBTQ plus health program, Stanford is really an amazing leader and can be be the beacon on the hill for a lot of these patients, not just in California, but outside of California, and particularly in the states that we showed that had the worst of the anti-trans legislation. And really excitingly, here at Stanford's Gender-Affirming Voice Center, we really hope to be a resource for these patients and be that additional beacon on the hill for vocal gender affirmation with these particular treatments offered. For neck feminization, we're planning on offering chondrolaryngoplasty for our trans feminine patients. In terms of vocal feminization, we're hiring a gender-affirming speech language pathologist to specialize in voice therapy for these patients. And we're the only place in the world that I know of that can offer 2 of the most common procedures sought after from trans feminine patients, including the open technique, feminization laryngoplasty, which I just discussed, as well as the VFS-RIC, the Korean technique offered in Korea, and Stanford being the only place where both of those are offered in one place, which is particularly exciting. We are also offering vocal masculinization therapies, primarily voice therapy, as well as type 3 thyroplasty, the Dutch technique that I mentioned earlier, here at Stanford as well. We're really quite fortunate that we work together as a team, particularly with our politicians and legislators. California, at the end of last year, as you may know, became the first shield state in the United States, being the first state to protect transgender and gender nonconforming youth who seek gender-affirming treatments, and also protect these patients and their families from criminal investigations and child abuse investigations too, that were being written into law in a variety of states, including Texas and Florida and Tennessee. So we're really supported by a really amazing infrastructure of local politics, but something that we can also improve upon, and with the privilege that we have as Stanford physicians, patient care coordinators, leaders in healthcare here at Stanford, to set the stage and really be, like I said, that beacon on the hill for these patients. So I'm really excited to join the LGBTQ plus team and family here at Stanford. It's my honor to bring my particular perspectives and to be a part of an incredible team within my division as part of, and also part of the LGBTQ plus healthcare team as well, to really have Stanford be the world leader in this regard for gender affirmation and a lot of the multifaceted care for our LGBTQ plus patients. So thank you so much for having me. Really appreciate sharing these thoughts with you all.
My gosh, thank you. Big round of applause, everyone, for Brian on this incredibly informative talk. I learned so much. I also had to look up the difference between a flute and a piccolo. I learned a lot about that. Thank you. We have a good amount of time for questions. I see people in the chat already saying, yes, thank you, Anne-Marie, that you are amazing. I feel so lucky that you've decided to rejoin Stanford. I know one first question, just quickly, folks asked if there was availability to have a copy of the presentation, if you're comfortable with that.
Absolutely, yes.
Great. If you'll get it to Peyton and I, then we'll send it to everybody that was here today. And then if folks would like to use the raise hand feature to ask Brian any questions or drop any questions in the chat, then I'm happy to pass these over. It looks like Kavita is ready to go. So Kavita, I'll hand it over to you.
Hi, Brian. I am really excited to meet you in person and be able to start working with you. I wanted to get a sense of kind of how long both the procedures take in terms of time, and if you see any concerns about doing multiple procedures at the same time, some bottom surgery or chest surgery at the same time, and kind of what does recovery look like for most people?
Yeah, absolutely. First of all, so great to meet you as well. I hope to meet you in person one day as well. Um, so both for feminization, both the VFS RAC, the endoscopic Korean technique, and the open technique, the feminization laryngoplasty, or FemLAR for short, both of those, in my experience, both of those tend to be, patients tend to, although this is could be a good research study, anecdotally, I felt that most of these patients either kind of seek out these procedures at the beginning as part of their medical and surgical transition, or towards the end, given that primarily these procedures narrow the glottis, and the sutures that we place can be quite fragile in the healing period. So we tell these patients for both of those procedures to try to avoid elective surgery within 3 months after this procedure is done, because anesthesiologists who may not be aware may unwittingly place a breathing tube through the stitches that may disrupt the quality and the durability of those stitches as well. So this is, of course, emergency or urgent surgeries notwithstanding, it's really important that these patients receive the life-saving care that they need in terms of surgeries and general anesthetics required. But in terms of planning and looking ahead, we often ask these patients to avoid elective general anesthetic in the 3 months after these procedures. To answer your question about the duration, I generally would do one or the other, and offer one or the other based on patient preferences. The VFS RAC, the endoscopic technique, takes probably about 1 to 2 hours for me at this point. And then the feminization laryngoplasty takes about 4 hours for me at this point too. Hopefully that answers your question, Kavita.
Yeah, absolutely. And what do you think about combined cases? Have you kind of seen any issues with doing cases, multiple procedures at the same time, gender affirming procedures?
Yeah, I think it theoretically should be okay. It depends, I think, on the gender affirming procedure. In terms of the post-op recovery process, coughing lightly is allowed after either procedure. Although I have my patients on strict voice rest for 2 weeks, so they communicate purely by text and by writing. Those are probably, otherwise there are no restrictions to diet. I do have the standard for a lot of surgeons, avoid no lifting more than 5 to 10 pounds after the procedure. If they have the open procedure, no bathing after 3 to 4 weeks after the procedure, and then waiting about 48 to 72 hours on the open incision. But endoscopically, they can shower and bathe, no problem. There are no eating restrictions for either of the procedures. So depends on the surgery that they're interested in combining, and I will definitely work closely with the other surgeon to help coordinate the perioperative care.
Awesome. Thanks so much.
Yeah, of course.
Exciting. Sounds like there's a good conversation to have there. I haven't heard of those surgeries being done at the same time, so it'd be great to see if the possibilities there. Siggy, I see your hand up, so I want to hand it over to you.
Yeah, so this may mostly be a question more about voice therapy than the surgeries themselves, but thinking sort of as WPATH has expanded to more directly recognize non-binary identities and goals that may not neatly fit into masculinization or feminization. What are you thinking about in terms of non-binary individuals? Someone who may want to access both directions, for example, or may have some kind of goal that doesn't neatly fit into either of those. How are you thinking about surgeries as well as therapy?
Really brilliant question. That's a really important consideration. I think it really goes back to patient customization and having the really appropriate preoperative discussion and patient-centered goals of understanding of what those patients particularly are hoping to achieve. I really have a thorough history taking where I really understand how they use their voice, how they anticipate using their voice in the future, personally and professionally, what risk trade-offs they are in terms of, as you kind of might have seen with some of the data, that there are pitch range reductions associated with both those procedures, and there even was a consideration of vocal power reduction as well. And so really customizing the risk-benefit ratio for these patients and understanding their present and future anticipated functionality. Voice therapy is, as you kind of alluded to, is a powerful tool in kind of customizing what those are, especially as folks like me who are gender fluid really experience their gender and how it changes over time. That can really be a powerful tool to adapt to that current understanding of how they want to express their gender through their voice. And so if there are particular changes that they hope to see that surgery can offer, having that really honest discussion about which features of the surgery are reversible, irreversible, which parts of the surgery can be customized to those particular needs based on anticipating the outcomes, weighing the risk-benefit ratio for those particular techniques too. Definitely a good discussion to have, really important discussion to have with these patients. And I'm so glad you brought that up.
Any follow up to that, Siki, or did that?
No, I think that pretty much answers it.
Yeah, that's great. It sounds like, if I'm understanding correctly, that you do have the flexibility to really meet what somebody's looking for in the ranges of specialty that you know how to apply that. And so non-binary could get a customized kind of set of work with you to be able to find that perfect pitch that they're looking for.
Absolutely. And I think it's that conversation is just so important. And I think the transparency of what surgery and therapy can or cannot accomplish, and what that really is my, it's really ideal, and it's one of my greatest goals for a patient to feel like they can understand what these surgeries and therapies can offer, and they can trust that there is particular expected outcomes and a range of things that can happen with surgery, and that customization is really ideal.
Great, thank you. It actually made me want to ask a follow-up question, and I know we have about 9 minutes left, so folks, if you have other questions, this is a great time. We've got some additional time. Brian, thanks for giving us, so please think of your questions. But I know there's some trans women who are actresses who are also like on Broadway and singing. And so if they were to access these surgeries, I know you brought up some, like, what are your goals? How would that impact something like their ability to sing? I mean, could it make it even better and get those higher pitches like you brought up in your training, or is that something that could be difficult for them moving forward? So I was really interested in that.
Yes, it's a really good point. There are really incredible transgender, gender-nonconforming professional voice users, including opera singers, actors, and I also consider in the category professional voice users teachers, lawyers, doctors, people who anyone who uses their voice for a living. I consider a professional voice user, and so choosing the right surgery for them, if surgery is indicated, that helps empower them and not necessarily impair their needs as professional voice users is really important. For professional voice users, I really lean towards the VFS-RAC, the endoscopic Korean technique, to provide and maintain the clarity of voice. Feminization laryngoplasty is quite a powerful surgical technique, but it can be quite aggressive, and it really eliminates the dead voice for a lot of these patients and eliminates their access to the dead voice at all. And so if pitch range preservation is really important to the patient, I really try to stay away from the feminization laryngoplasty, and the VFS-RAC is a lot more. There are no research studies out there, and it's a big research opportunity, but in my experience and my observations, the VFS-RAC, the Korean endoscopic technique, has a much more well-preserved clarity of voice post-op compared to the feminization laryngoplasty.
Great, that is amazing. And clearly I see the distinction there. So thank you for walking us through that. So I have one last question. And then if anybody else has a question, and then Anne-Marie, I want to hand it to you as well. But what about your patient load and capacity? I believe you've gotten started, but how many of these, like how do we direct patients to you? Hopefully we're not to a wait time yet. How many focused on gender affirming work and consultations are going to be opening up? We're coming up on Pride, and so we'll be doing big marketing campaigns, and want to make sure I know how to talk to patients about this opportunity.
Absolutely. So Thursday afternoons, I have slotted for completely for gender affirming telehealth initial visits, where I first meet the patient, introduce myself, have them have me be a resource to them, and for me to understand their initial goals kind of coming into the consultation. Before we meet in person, we do a scope exam and a full vocal assessment. And right now, that Thursday afternoon is wide open. And so would love to see any and all patients who are interested in learning more about the surgery as they go through their voice therapy, as they explore through vocal coaching, as they kind of come into their own and just want to have a discussion about vocal gender affirmation and have customized, just a really, private custom session of understanding what we offer here and where they are and where they hope to be. They don't necessarily have to sign up for surgery, but just kind of just a consultation with me overall is very much welcome, and it's wide open right now. So yeah.
Great. Thank you, Brian.
Yeah, just wanted to quickly say I'm part of the Pride ERG, and obviously, as you just mentioned, there is some availability. So how do people that are interested in that get in contact with you? What's the best way? Assume that they have a Stanford primary care provider and that they don't. Who do they send that referral to, or how do they contact you?
That's a really great question. I will send to Blaze a patient handout that I have that has a kind of a brief patient-centered description of what the procedures we offer at our gender-affirming voice center, as well as the contact information for patients and contact information for providers that patients and or providers can reach out to schedule appointments with me, either through a referral form request, or through a fax line that providers can send referral documents over to, or even also an appointment hotline that patients can use to call to create an appointment. We have a workflow right now that I am almost 100% sure we're going to modify as we receive patients and as we grow this practice. Especially those who we dialogued with here within the Stanford community as healthcare providers, I'm open to feedback about what the patient experience is like, especially as we navigate, as these patients navigate large healthcare systems like Stanford too. So I'm really eager to making sure that experience is as friendly and affirming as possible as they navigate their way towards me and other providers too.
Great, thank you. And Brian, will you be doing these, do you know where these surgeries will take place?
Right now I have block time in Emeryville in East Bay,
Okay.
Although in my discussions with my division chief and chair, potentially slots at Redwood City and Palo Alto, although that's not set in stone yet.
Great, okay. And then I see one question about insurance, and then after that we'll go to Anne-Marie.
Yes, really great question about insurance. Right now, a lot of different insurances can cover gender affirming surgeries. We're taking on a case-by-case basis right now because this is a new procedure. These are new procedures that we're offering here at Stanford. So an ongoing discussion, and I'm working closely with the billing department to kind of help each individual patient get through to having these procedures covered. We are also offering a self-pay option if unfortunately that insurance feature is not covered, and my goal is to minimize the cost as much to the patient as much as possible to make sure the self-pay option is as reasonable as possible. For example, operating at a private surgery center, not within a Stanford's surgical center where the fees can be a whole host of order to magnitude higher. So customizing that to make sure the self-pay option is as low as possible and as reasonable as possible. But of course, preferential to insurance coverage and really fighting for that coverage, working with my billing department for that. So custom-based case-by-case basis, and we will see per patient.
Thank you. That's wonderful. Thank you so much, Brian. Let me hand it over to Anne-Marie.
Thank you, Blaze. And Brian, amazing work. So thank you. Thank you for being here at Stanford. I mean, it's a service that we've so excited to have. And Blaze, thank you. All right, I know you're a driving force. Again, everyone, my name is Anne Marie Yap. I am one of the co-chairs and leads for the Pride ERG and also for the LGBTQ plus subcommittee for Stanford Medicine. What I want to let everybody know is May 10th, we're going to have an on-site event over at the 500p Assembly Hall. It's going to be a reception, mini all hands, kind of get us all back together as a community. Everybody's going to be invited. We'll send out notification. I've asked Blaze to be one of the speakers just to present his program, to get more word out about the health initiative, but also review some of the things that the working groups have been working on, right? That impacts our community. So thank you, Blaze, for the opportunity just to mention this event, but I would love to see everybody there. And of course, I'm trying to just make sure that there's snacks, beer, wine, and food for us to just really get to know each other. So thank you. And Brian, thank you.
Thank you.
Well, thank you both. And big round of applause again for Brian for being here today and for joining our team. I can't wait to see all that you do, and so honored that we get to work with you and to offer this service that really, as you said, is sought after and rare to be able to obtain. So how awesome. Okay, thank you all. I'll share the materials after this. And Brian, yeah, any parting words?
No, thank you so much for having me. You know, one of the things that I value the most is in my personal and professional life in terms of meaning that gives me the meaning the most is connection and community. And so especially as a queer person, a queer healthcare provider, love to connect with our queer healthcare providers and allies here at Stanford. And you know, when I was a resident here, that was really important to me too, being part of the house staff LGBTQ plus group, and so excited to work with all of you, and it's very healing to be here with you all. So thank you.
Beautiful note to end on. Thank you, everyone. Take care.
Have a great weekend.
Thank you.